Hey, Dr. Divi, it looks like Dr. Patel is closing in his last case, so he may not be here right at the beginning, but I'm sure he'll join us before too long.
Yeah, sounds good. And I'll just give it like a couple minutes and just get started. Give some people time to log on. All right, let's just get started. Wow, we got both the chiefs together. Look at that. Although disappointed that Joe doesn't have his mustache, but let's get started. We'll talk about thoracolumbar trauma. You guys are pretty familiar with this. You guys are just seeing my PowerPoint screen, right?
Yes.
Okay, good. All right, so this is a cool picture here. This is an acute traumatic spondylolisthesis at L5S1 with basically spondyloptosis, high energy trauma. So we'll just go over background, eval, classification, treatment, special conditions. Don't memorize any classifications. It's kind of just understanding how to group injuries because there's such a disparate, wide-ranging group of injuries that it can be kind of confusing. So it's just a way to kind of organize them in your mind. And that also ties into treatment. And so different classifications have worked on, just going from morphologic classification to then prognostic classification with treatment options, just to kind of standardize spine treatment across the world. And then we'll talk about some special conditions. 1 second, give me. So majority of spinal column fractures are in the thoracic and lumbar spine, most of them occurring between T11 and L1 because, it transitions from a rigid thoracic spine to a mobile lumbar spine. Most of the patients are young male and high energy mechanisms. About 30% of fractures also occurring from L2 to L5. So the majority from T11 to L5 is where you'll see most of them. You can also have complete neurological injuries in about 20% of patients, incomplete in 15% of patients, obviously not as high as cervical injuries. So associated injuries can occur half the time. So you're going to be paying attention for concomitant fractures. This is your standard trauma evals you guys are used to. They should evaluate for head trauma in terms of the general surgery team, but you guys should also keep an eye out for that. Pulmonary injuries, intra-abdominal injuries. Main thing you guys should pay attention to is non-contiguous spine injuries. So just because they have a lumbar spine or thoracic spine fracture, if there's any concern on your physical exam for something higher up, then I would image the entire spine. Because the consequences of missing a spine fracture is pretty devastating. So 1 second, let me change this window over here. This is kind of a good picture to kind of illustrate what happens in different areas of the spine. So, basically for a balanced spine, you have head over pelvis. So the EAM over the femoral heads and the sagittal view. And the thoracic spine is kyphotic, so you get compression across the anterior column and tensile forces, distraction across the posterior column. And then when you get dropped on a lumbar spine, because of lordosis, you get tensile forces in the anterior column and compressive forces in the posterior column. And also the orientation of the sets. You know that in the thoracic spine, they're kind of coronally oriented, so you get kind of bending. And the lumbar spine, they're coronally oriented, so you get flexion extension. This is a good picture to kind of understand how injuries occur. For here in A, you have pure axial loading that can cause, compression fractures anywhere along, depending on, what we talked about. If it's in the lumbar spine, because of that compression falls along that anterior column, it's going to have compressive or middle column compressive forces. It can cause a burst fracture. Flexion mechanism, flexion distraction can cause either like compression or burst type fracture. Lateral compression can cause asymmetric kind of burst fracture. Shear injuries are pretty devastating, and I think they're more likely seen in like high energy injuries, like motor vehicle accidents or like pedestrian versus auto. And those results in fracture dislocations. Extension injuries are, you can think about the fulcrum of injury as being behind the patient. And so the anterior column of the spine sees extension forces and compressive forces along the posterior aspect. Interesting kind of corollary between this flexion injury and then this kind of rotational injury depends on where the fulcrum of rotation is. This is anterior to the anterior column, right? So depending on how far out it is, you can get a complete disruption starting from the posterior ligaments, extending through either bone or ligaments into the disc space. And it can either be incomplete or complete, depending on kind of where the rotation is. This is your classic, what's been described as a seatbelt fracture back in the day, before they got, their new modern seatbelts. This is, if a transosseous fracture, that's like your bony chance fracture. Otherwise, you have your osteoligamentous chance fracture. Then you can also have rotational injuries. So, ATLS protocol, all spine injury patients should be immobilized on a rigid backboard to protect the entire spine. Cervical spine should be immobilized in the prefabricated collar, even if it's only, lumbar injury, until you come clear of them, basically. So a team of 3 people or more should roll, and ideally you're the 4th person assessing the spine. So one person stabilize the head, one person for the extremities, or the torso, like shoulders and pelvis, and one person for the legs. Look for ecchymoses, tenderness, deformity, step off, and again, the entire spine. Thorough neurologic evaluation. This is usually done, but if the ED team or the trauma team doesn't pick up on this, they'll leave them on the backboard, get them onto the actual bed. This is the Asia classification diagram you guys are all pretty familiar with. I'll just go over some pertinent, important ones. So first, you're assessing motor, sensory, and reflexes, right? So motor, you guys all know how to do. One thing I'll point out is that this Isinski, one who made the Asia classification, you classify a 4 out of 5 as active range of motion against resistance. A 3 out of 5 is full active range of motion of the joint against gravity. So like if you're grading a 3 out of 5 for the quadriceps, I want them to be able to like fully lift their leg up through the full extension. If there's like an extensor lag kind of thing, I would just kind of grade that as like a 2 out of 5. It's hard to test in a spinal cord injury patient a true 2 out of 5, which is full range of motion of the joint with gravity eliminated, because you're not going to roll them to the side. Test their hip flexor and quadriceps with the gravity eliminated, but you can kind of do the best that you can. And it's probably better to downgrade than upgrade their strength, because it'll kind of create a confusing clinical picture for you later. The other thing to talk about is complete versus incomplete injuries. And I'll go over, is Steve in with Patel? Manish?
Yes.
Yeah, okay. Well, then I guess I'll pick on you then. What is, well, actually, are there other juniors? John?
Yeah, I'm here.
Yeah, John, what's difference between like complete and incomplete injury kind of in the acute spinal cord patient? Like, what are the pertinent physical exam findings?
So I think in an incomplete injury, you can have sacral sparing, you can have some sensory retained distal to the side of the injury, and then intact like bowel bladder function.
Correct. Yeah. So, you know, if there's some sensation to light touch, that's pretty obvious in complete injury, despite no motor function. If there's an apparent complete injury, like they can't feel light touch, most of us probably don't do pinprick, but you know, that's part of the thorough Sinski kind of classification. If you detect sacral sparing, which is the S4 or 5 dermatomes, with deep anal pressure, voluntary contraction, that's supposedly a good prognostic sign of neurologic recovery. So the apparent complete injury then becomes like an incomplete injury, and that tells you like you should move fast because this patient has a chance of getting better. You know, another thing that can affect your exam, right, is a spinal shock. What is spinal shock, Kelly?
The spinal shock is the acute phase in which the spinal cord or the spinal cord function is not fully intact, and it can you have to wait till they're out of spinal shock to fully determine the extent of injury. Correct.
Yeah. You know, again, you can't determine if it's a complete versus incomplete until they're out of spinal shock fully. And then another good prognostic sign is that if they have sensation, if they have apparent, you know, complete motor deficits, and they have, you know, sensation to pinprick, that's a better prognostic sign than just sensation to like proprioception or sensation to light touch or proprioception, because I think about 50 to 70% of those patients may get motor function back up to 3 out of 5 strength. So that's another important kind of determination. And you know you're out of spinal shock when you have return of reflexes, the bulbocavernosus reflex. All right, enough of that. So radiologic evaluation, spiral CTs, obviously have supplanted other imaging techniques quick. You should get 2 to 3 millimeter cuts, which we'll do here at our trauma center. In the cervical spine, 1 millimeter cuts are helpful. The other regular CT scans are like 5 millimeter cuts, so it needs to be fine enough to determine fracture patterns. MRI is, you know, indicated when you have neurological deficit or you're assessing for ligamentous injury. For example, posterior ligamentous injury, determining stability. So if there's any question of ligamentous concern, then I would get an MRI. If there's an obvious neurologic deficit or continued neurologic issues, then I would get an MRI. So it's a complementary study rather than like a substitute. Radiographs are good to obtain, and even if you have spiral CT and MRI, I'll still get radiographs because, you know, for example, let's say it's an instability picture, you can use radiographs to track the patient over time. For example, if you place a patient in a brace and you want to see their degree of collapse or kyphosis over time, assessing their alignment is helpful with radiographs. Upright radiographs. And I'll just quickly go over injury classification. It's kind of boring, but I think just hit on the salient points. We'll classify the integrity of the spinal column, with mechanical stability and neurological stability. That's the point of the classification systems. And then over time, certain fracture patterns and associative injuries, have been sort of categorized. So this, you may have heard, for example, last week, Dr. Patel went over the Allen Ferguson classification for like the mechanistic criteria for cervical fractures, similar ones in the lumbar spine. Ideal system should be simple, reproducible, and serves as more of a communication technique between surgeons. And like I said, should move us towards kind of standardizing care for a certain injury. I think you guys are probably familiar with, or maybe should know, Holdsworth came up with like the 2-column definition of spinal stability. And then, which you're probably familiar with, is the Denis classification from '83, which is kind of elaborate that to the 3-column. Then in 2005, Vaquero kind of popularized the TLIX classification. So we'll go over those. So Holdsworth talked about the anterior column, which resists compressive loads in the thoracolumbar spine, and posterior column, which resists tensile forces. And then the Divi three-column theory kind of separated that anterior middle part into anterior column involving the ALL, anterior annulus, and the anterior 2/3 of the vertebral body, the middle column being the posterior third, and then the posterior annulus, PLL, and then the posterior column being everything afterwards. So pedicle on back, including all these ligaments. Here's another picture kind of depicting the thoracic spine, the anterior, middle, and posterior column. I think this is just a good way to kind of think about it, not necessarily that you'll use this certain kind of nomenclature, like talk about anterior middle column injuries. It's just a good way to think about it. So here are kind of 3 pictures depicting different kinds of thoracolumbar injuries. Now you can classify them, using you think about this as like a flexion injury or an extension injury or rotational translation injury. If you go with like the Divi classification, this is would be like a coronal split fracture. This would be kind of like a compression fracture. That's what we're commonly used to saying. That's where, when we talk about compression fractures, comes from that Divi classification. So compression is like 1 or 2 end plates or vertebral body. Burst fracture is where you have both end plates involved, or it goes to the posterior vertebral body wall, and you can have significant loss of height. There can also be rotational components or translational components to injuries. And then this is is kind of a flexion type injury. So the chance fracture that we were talking about, it can be transosseous like this, the bony chance fracture. It can be purely ligamentous, discoligamentous, or it can be osteoligamentous. And you can have injuries where it goes ligamentous at the level above and osseous and disc related at the level below. So here, Manish, these are like several pictures of like axial cuts for like a vertebral body fracture. What do you see from like the top left to the bottom right?
So it looks like there's an axial load here applied to the vertebral body. There's a burst fracture.
Yeah, it's starting off. Well, what's the top left? What do you see there? Would you call that a burst fracture?
No, I guess you see a combination of the vertebral body anteriorly. Looks posteriorly, it looks like
looks good, right?
It looks like the facet is well reduced. It looks like the bars are intact. You can see a little bit of transverse process or fracture there. It all looks the anterior body.
Yeah, exactly. So I think the point just trying to make is that these are all different people, different fractures. If you just look at the fracture pattern and like a cut, mostly it's just the anterior aspect of the vertebral body here that's kind of fractured, right? There's some disruption here posteriorly, some disruption there anteriorly. Here it's more obvious. There's a discontinuity in the posterior vertebral wall, and there's some lateral disruption here. This is pretty obvious. There's like a split fracture here. It's going back through the posterior aspect. The posterior cortex here is disrupted. And then here, very obvious, this part of the body has been pushed back into the spinal canal. And then here, so that we call this retropulsion of the posterior body. And this is pretty severe spinal canal stenosis secondary to this bony retropulsion. Go over the TLIX classification because it was kind of the first attempt to take all this nomenclature and then make it prognostic. So we have, for the first time, using the terminology compression, burst, translation, direct distraction, and then assigning a certain weighting to it, assigning weighting to a possible ligamentous disruption, and then also a patient's neurological status, combining all of this to determine what to do with the patient. before that, it was sort of, kind of a judgment call based on neurologic deficit and what people thought was stable versus unstable. So on the lower end, compression fracture intuitively is pretty stable. It's just that very anterior part of the spinal column that's disrupted. As long as there's good alignment, non-progressive, kyphotic deformity, then you would assume that they would heal fine and do well long term. So that's kind of a sign 1 point. If it's a burst fracture, extends to like that posterior body wall, that indicates more stability, right? Instability. So now you add another point. Now, if there's distraction or translational rotation, that's much more disruption of the ligaments and the disc, and much more of a sign of instability. So you add more points. Posterior ligamentous complex, also, pretty important for maintaining spinal stability in terms of tension or flexion and translation. So these types of injuries are likely going to have suspected or injured PLCs. They specifically put suspected or indeterminate as a 2 point versus like a 1, or like keeping this as 0, 1, 2 to try to increase weighting towards possible intervention. This is determined on axial imaging, either CT or more commonly MRI. And neurology, this is the neurological status of the patient. So if it's like a nerve root injury, that's less concerning than obviously a cauda equina. So 4 is a decision point to make for the surgeon, and based on kind of the whole clinical picture. AO spine classification was introduced later on, earlier, like about a decade ago, to kind of combat the shortcomings of the TLEX classification, because a lot of, let's say if you have like a burst fracture, indeterminate PLC disruption, but they're intact, what do you do? That's a 4. So like, would you be aggressive and stabilize them, or wait, see how they do? So that's where AO spine classification was brought in to try to clarify this. You don't need to memorize all this, but just kind of know, like as with your other AO classifications, type A, B, and C goes from more benign to worse. So type A is minor fractures. So you think of the compression fractures, that coronal split fracture that I told you about. This is still pretty stable because of the intact posterior body. An incomplete burst fracture, meaning there's a burst fracture extending to the posterior vertebral body, but only one end plate is involved. Here's a complete burst where both end plates are involved and it's going all the way back. This is much more unstable. So this is one to watch versus this. And so that's what this classification tried to differentiate. Type B are tension band injuries or distraction type injuries. So this gives higher weighting to possible ligamentous injury. And then obviously type C injury is like a dislocated spine. So that should be kind of at your forefront for intervention. Immediately, if you see a type C injury, you got to act on that. There's also different modifiers. So going from incomplete to complete injuries, and then type of, for example, if they have ankylosing spondylitis or other indeterminate findings. So kind of like the TLEX score, they tried to assign injury scores using the AO classification. And one thing I'll just point out, similar idea. The reasoning for this is, let's skip to here. For example, we talked about the TLEX score, right? Like the increased weighting for suspected indeterminate. So you kind of determine that based on CT, MRI, if there's a wide interspinous space, increased T2 signal or T1 signal, or disrupted ligaments on T1, where you see facet distraction, subluxation. Those are all kind of obvious, but it's usually less obvious than that. So it's difficult to assess accurately. In the AO spine, the main distinction for the AO spine injury score is kind of here in the type B injuries, differentiating between an osseous disruption versus an osteoligamentous disruption, because they assign different weighting for that. And because, if you have a pure transosseous disruption, theoretically, it could be more stable. So that's kind of the thought process behind both the different scoring systems. And there's a little bit more definitive, the thought process to make it a little bit more definitive for with the AO spine classification. I don't routinely use these in the clinic, or sorry, in the for consults. So, to me, I kind of group them into A, B, and C in my mind, and then determine stability based on what the imaging findings show. So like it basically, I look at the posterior ligamentous complex, if it's the middle ground, and determine if it's disrupted or not. The shortcomings of TLIX, with the comminuted burst fracture, the one kind of that I described earlier, that the AO classification was designed to address. Here's an example of a burst fracture that went on to collapse significantly, and the patient had significant kyphosis that was fixed. So I guess the theory is like you could wait and see how they do, but if it's probably easier to fix in the acute setting versus when they collapse, then it becomes like basically a deformity operation. Again, we talked about this. So the surgical goals for thoracolumbar fractures are restoring alignment, fixing stability, and alleviating any neural compression. This is our surgical goals for any spine surgery, but specifically in terms of fractures, you got to consider a number of things. For example, would you go anterior approach versus posterior approach, or both? And this is, you got to consider the level of injury. For example, the thoracic spine, anterior approaches are harder. Got to consider neurological status, neurological compression based on MRI, availability of access surgeons, total overall medical condition of the patient, number of segments to be stabilized. This kind of brings to mind that ICU patient that we have currently, who has that, clear type B injury, right? It's like a type B2, kind of a flexion distraction injury, the chance fracture type patient, and he hasn't been stabilized really. He's can't go prone for surgery, and it's been about 3 weeks since he came into the hospital. So he needs clearly about 5 segments stabilized, 2 above, 2 below the fracture. Again, we talked about the approaches for the thoracic and lumbar spine. For the thoracic, you can go transthoracic or thoracoabdominal, kind of in a lateral approach. In the lumbar spine, you can go transperitoneal, which we don't really need to do anymore, but if he has other concomitant injuries, may be a possibility. If there's, the retroperitoneal approach gives you great access to the anterior column for fixing, significantly comminuted burst fractures with like a corpectomy. Finally, posterior approach is going to be your main kind of workhorse approach. You can directly decompress. You can get distraction across the segments to get some indirect decompression. So you can do transpedicular decompression to get all the way to the anterior column. And then finally, in the thoracic spine, you can do lateral extracavitary approaches. So take down part of the rib, go very lateral, and get significant access to the spine to reconstruct the anterior column from the posterior aspect. Here's an example of showing how to get distraction of a burst fracture. So it's kind of like, in the rest of ortho, if you think about like, relative stability, kind of like bridge plating. That's kind of what you're doing here. You point the screws kind of together, and then you kind of distract up, and then you can kind of try to restore anterior column height. Here, you're relying on the posterior column to get rigid fixation. So if that's compromised, this would be pretty hard to do. And you're relying on indirect decompression unless, you take off the lamina and then do a direct decompression in the canal. Other things that we didn't really touch on, but you should be aware of is there can be traumatic durotomies. So a lot of times with, bony spikes fragments that go into the canal, they can, cause a durotomy, and then you're dealing with CSF leak. Unless you just kind of leave it alone, it might heal in place. So there's some controversy on doing a short segment fusion. So for example, if you have a comminuted burst fracture, how far do you need to go above and below? For a burst fracture, I think you can sometimes get away with one level above and below, depending on the fixation you get in at those levels, and depending on the location. If it's like mid lumbar spine, you want to try to preserve levels, then I think it'd be reasonable to do one above and below as long as you have good fixation. Historically, we've always done two above and below. And then for people with, stiff spines like ankylosing spondylitis or dish, we consider three above and three below, because it's that much harder to keep that stiff spine more rigid to get a union.
Dr. Divi, quick question for you. So you mentioned that ICU patient we have. So let's say that this guy gets to the point of medical improvement, where he can undergo surgery. Would you ever consider doing just a one level for him, because he's not, unfortunately, because of his DAI and just his overall status and prognosis, it's unlikely he'd be.
No, I don't think so. You mean one level, like what did he have? He had L1, right? He had an L1 injury? Yeah, what would you suggest meeting one level, like L12, T12L1, or?
No, sorry, I meant like one above, one below, like the short segment instrumentation as opposed to the long segment.
Probably not at L1, because that's the thoracolumbar junction. And if he had a true like 3-column injury, meaning, he has clear fracture through the pedicle on one side, partial fracture through the other side, clear disruption all the way through the vertebral body. He likely has significant posterior ligamentous injury. And sometimes you see that when you go in and expose, you see the ligaments completely torn. At the L1, the thoracolumbar junction, that sees a lot of stress at that level. I'm biased, and I would go minimum 2 above and 2 below. I think you would probably get away with 1 above and 1 below, maybe, like I said, like mid lumbar spine. But that being said, I think it's all patient dependent. Like, you might be able to get away with it, depending on how much other stability he has. And for that guy, he's probably not going to be up and moving. So maybe it'll work, but at the same time, no, it doesn't take that much longer just to add another couple of segments.
That makes sense. Thanks.
Yeah. And he's a good example of where you don't need to do a decompression, right? Or we don't know, but at least on MRI, there's no need to do it. There's no stenosis or foraminal stenosis or canal stenosis, but we don't know his neurologic exam. But you could do a percutaneous, like 2 above, 2 below. There's another kind of literature on there, kind of thinking about trying to determine stability of burst fractures in different planes. So if you think about 1, 2, and 3, like a little more in gross, like instability in the sagittal plane, in the axial plane, and in the coronal plane, it's kind of intuitively thinking about how much more disrupted is the bone. Is it partially or complete in all different planes? You kind of add that up. And so a completely disrupted, vertebral segment in all 3 planes, much more likely to fail. And that anterior column needs anterior column support. So you need to do something there. And then we talked about ankylosing spondylitis and dish briefly. These are important because it's a bone stiffening disease. Here's an example of a patient that has a 3-column injury and ankylosing spondylitis. As you can see, the bridging bone and clear preservation of this space there. This is hard because it's 2 rigid lever arms above and below, and so using a short segment fusion to kind of hold this together will fail. It's like using, like for like a femur fracture, if you're plating it, it would be like doing like one or two holes on each side. Like that's not enough, right? You got to do like an 8-hole plate kind of thing. Like you got to do 4 on each side. That's similar kind of concept. So here's an example of that guy reduced, and typically, put him on the table, you should be able to reduce. This is another example of this patient. I think this is the same patient that I think had further, or no, he might have healed in that position. Yeah. Here's an example of that thoracolumbar kind of T12 area burst fracture. Now this is kind of bordering on type C injury. I think it's like a little bit of translation there. It's either significant retropulsion of bone causing significant cord compression. So in this case, you have to think about what you're going to do to stabilize the patient as well as decompress the patient. So decompress, are you going to go anteriorly or posteriorly, and how are you going to get this piece of bone out? In my mind, I would, to get ventral to the cord, to get all this out in the area of the spinal cord, you have to take down a pedicle and do something to tamp it forward, or you have to go lateral and get full exposure of that posterior body and decompress the ventral compression. So here's an example of going transpedicular, and they did a LAMI, and I would have gone even one more down to get 2 above and 2 below, and decompress that area of the T12 burst fracture. Here's an example of an injury at L1-2. Let's see, John, can you kind of tell what's going on at that L1-2 level? I'm just giving it away that there's an injury there.
Looks like the vertebral heights are maintained. The end plate looks maybe a little funny on L2 superior end plate, and then maybe the pars. No, actually that looks normal.
Mm-hmm. Well, yeah, the other thing, one thing we kind of skip over that should be, we should really pay attention to is the spinous processes. It's subtle, but you see kind of the distance here. It seems like it's a little bit more here, right? Yeah.
Gotcha.
Yeah, so this is a great example where there's not much of a bony injury, but there's a clear ligamentous disruption. So this is guy's x-rays standing up. And so that's like significant disruption, right through the ligaments and right into the anterior column. So here's an example. They did one level above, below. I probably would have done 2 above, 2 below. So clear example that needs to be stabilized with a 3-column injury. All right, and finally, Eric, can you see what's going on here on this AP?
I'm just zooming out my phone here.
Yeah, sorry, fuzzy picture.
I know 2-3 looks a little weird, like there's a little bit of distraction between the two. It's just kind of,
Talking about like here?
yeah, but it's kind of tough to see. I can't zoom in anymore, unfortunately.
Yeah, what about up here? What does this look like?
It looks like, you got some, yeah, you have a compression vertebral bodies for sure. I don't know, it's just kind of tough to tell on my phone.
Yeah. Oh yeah, sorry, you're on your phone. So just this subtly is wider. You see pedicles, spinous, and body.
Oh, absolutely.
This is like a little bit more pancaked. Pedicles are wider, and this is back kind of more normal shape. I got to work on finding a better example of that. But then this is the sagittal view. And so it's clear type C injury, right? This is a fracture dislocation of the spine.
Most definitely.
So this is just an exercise in like noticing subtleties on the AP X-ray. obviously you'll have the lateral x-ray, you'll know what's going on. Just that, I believe that same patient, severe cord injury there. And so this is an example where, you know, you need to, I'm not sure if posterior would be enough. I would probably do a corpectomy here and get rid of, because to get rid of compression all along the cord at that level, or the conus, I'd probably do a lateral corpectomy. And as long as this is intact, this end plate, just that one level, then either, depending on if you got a full decompression, may not need to do any posterior decompression, and then at least 2 above and 2 below, if not 3. And it looks like here used probably, this could be a fibular allograft. Other things you can use when you're going in through the thoracic spine, Eric, what else do you think you can use?
I know they have the. I mean, I know they have like the cages, but I mean,
Yeah.
outside of a fibular graft, yeah.
Yeah, fibular allograft. Use ribs or rib strut autografts are thinner and not as good as the fibula, but that's another possibility. Otherwise, we can use like, you know, one of those $10,000 corpectomy cages. Those are pretty nice too. Whatever you want. And definitely you'd have to flip them to the back and then stabilize them too. Here it looks like they put in lateral. So you see this right here, this lateral vertebral body screw. So it's going in across the body here and here, and then a lateral rod. So it's kind of like a pedicle screw that's just going across the body. Try to get bicortical fixation there, and then you got to make sure it's not in the way of your pedicle screws here. All right, that's all I got. I gotta find some more good examples of trauma cases for you guys that will, there's been some good ones rolling in, so kind of add that on for next year.
I've got
Any
one-
questions?
Oh, I was gonna say I got one quick question, and that's just for a burst fracture that you're gonna fix that doesn't need like a laminectomy, no decompression or anything, like percutaneous screws versus doing fusion. Like what's the thought process for when you would need to do an arthrodesis versus when you can just do perc screws?
Yeah, that's a great question. So like the perc screw is along the thought process of like kind of internal stabilization till it heals. And then, you know, some people are advocates for taking out the instrumentation even. Maybe I wouldn't bother with that unless it's like a really young patient with a, you know, like a skeletally mature patient, but like, you know, if they're like 16, 18, or even they're like young 20s, you can consider doing 2 above, 2 below, stabilizing them, or even 1 above below, and then removing the instrumentation later. I would do that percutaneous. You're not trying to fuse. At anyone else, I say, why bother? I mean, the goal is to, you know, keep the alignment optimal, and, you know, why bother risking it from if you're not fusing and having the alignment worsen. So I'm a proponent, I think, but I think that's a lot of bias from training from fellowship. I know Paula Patel thinks like that too, and I think most of kind of how we approach cases here are like that. Unless, you know, for example, one good example is that guy in the ICU. He's about 36. Percutaneous stabilization is good for him because less blood loss, and he's a very sick guy. So it'd be less traumatic, less tissue trauma too for him. That's another option.
Awesome, thanks.
All righty. Any other questions, thoughts? Yeah, so I think, you know, we've had some good examples of kind of thoracolumbar injuries that have rolled in terms of consults. But, you know, another thing I think I didn't mention to keep an eye out for, this is pretty rare, but like conus injuries. So conus level can present a little bit different than like a true spinal cord injury. It's somewhere in between like cauda equina and a spinal cord injury. Like they can have kind of sacral deficits, but no real motor deficits. So it can be paint a confusing picture. So I think, you know, in an acute kind of traumatic or traumatic setting, it's important to do kind of like the full neurological exam to get a full kind of eval. But that's pretty much it. And then we'll kind of go over, I don't know when the next meeting is, but obviously it'll be in December. We'll try to do 2 a month, and then we'll split up the topics. I think we're going to get into degenerative conditions. So like lumbar and cervical degenerative conditions, and then move on to like tumor, and then stuff from there. So, all right, guys, thanks for joining. Then I'll touch base about the next lecture.
Hey, Dr. Divi, I
Thanks,
do have
everybody.
one
Have a
last
good
question. Sorry.
Yeah, go ahead.
For the patients that have burst fractures with significant retropulsion, you do get a traumatic durotomy. Like, how exactly do you address that lateral? Because then you can like decompress them and then have a better access to the ventral aspect of the dura in order to do like a primary repair, or?
That's a good question. I don't know. I haven't directly seen many. Najib, do you have any thoughts on that? Have you guys seen that on the neuro side at all?
I missed part of the question. So it's traumatic CSF, right?
Right. Like if you have like a traumatic durotomy from like retrobulbar bone fragments, like let's say if the tear is like ventral,
Yeah,
like
this
cord
is like-
level or like ventrolateral, what do you do?
Most often, if you're there and you get to it, like you could put like gel foam around it, then lumbar drain and let it drain forever. So you're not going to be able to repair it unless if it is something like lumbar and it's easy to access. Yeah, but like if it is something higher up where you cannot reach it. Now, depending if you have spinal cord injury and you want to manipulate things around, that's another variable. But saying someone is intact, you would just like try to put some Duragen around it, T-seal or Duracell, and then lumbar drain for a long duration.
Yeah, it makes sense. What's a long duration? Like 1 week, 2 weeks?
Yeah, more than 5 days. 5 days is typical, and then going to 7 days, something like that, is considered like longer. But like a lot of people would be happy with 5 days of drainage.
Okay. All right. Cool. Well, there you go, Eric.
Thanks.
Yeah, thanks, Najib. So it always helps to have a neuro person on here. All right, we'll touch base again next month.
Awesome.
See you guys.
Thanks, everybody.
Yep.
Thank you.
Thank you.